Now you do.
Well-known, well-loved, the best neurologist that Austin, Texas has ever had.
Debbie.
I'm not talking about clinical skills.
She gave me $20.
I'm not talking about smarts. I'm talking about a doctor that comes in, and even if the patient is head injured, paralyzed, developmentally delayed, no matter what is going on with them, Dr. Morledge always talks with the patient, engages with the patient. He will sing with them. He will do whatever he needs to do to have that personal connection and relationship. And that gets 5 stars for me, always, as a nurse. So he has been in Austin forever, garnering lots of patients, lots of good relationships, and he is now some kind of professor with UT Dell Medical doing neurology in a clinic over there. So he is continuing to work in this community, and we're so very, very fortunate to have him. And when he's finished with his presentation, we will have a entertainment by Dr. Morledge, and then we'll have questions and answers. But I have one quick announcement or question. Is there anyone here with Parkinson's who regularly sings? You have regularly done singing, because there's a study on the correlation between singing or music and Parkinson's. Is there...
Or even play a musical instrument. That was the other inclusion criteria.
So anything musical, anybody, you could be a special person in a special study. Anybody? Y'all are?
I'm volunteering my husband.
All right, we have Jesse.
Yes,
Okay.
I've already signed up.
You have signed up already, thank you. 2 people. All right, so let's give a warm welcome to our last speaker of this year, Dr. Morledge.
Thank you so much. Well, it's great to see everyone, and this is going to be a very, it's a give and take tonight, okay? And we are going to do a little sing-along at the end. But anyway, I wanted to sort of take a trip down memory lane and just let you know where the practice of neurology has gone over the last 40 years since I started practice. And, looking back, our group covered Brackenridge, Seton, St. David's. I had to drive to Round Rock because there wasn't a neurologist in Round Rock, if you can imagine, to see consults in the hospital and whatnot. But back then, when we first started, in medical school, during your 3rd and 4th year, you do clinical rotations. And you find a mentor that you look up to, a role model. And the joke back then was, why would you want to be a neurologist? Because the running punchline was, we can tell you where the lesion is, but we can't do anything about it, And so now, fast forward 40 years, I can, thankfully tell you there is a lot we can do from a neurological standpoint, depending on your diagnosis. So for example, back then, if you had MS, multiple sclerosis, it's an autoimmune condition, your immune system decides to turn against you and attack myelin, which is the insulation around your nerve. All we had back then were steroids. That's all we had. And so over time, fast forward to now we have 26 different MS medications we can use. Back then, if you had a devastating stroke and hit the emergency room door, we didn't know anything about this time is brain. You've probably heard that. You need to get into the hospital as soon as possible if you have TIA-like symptoms. Back then, you were literally pushed on the gurney into the back of the ER, and we'll get to you when we get to you. And everyone, if you didn't have a hemorrhage in your brain, everyone got heparin and Coumadin or warfarin. And so, now we have thrombolytic agents, we have very sophisticated catheters, we can put up arteries and retrieve clots. So it's just really rewarding now to be a neurologist. And specifically about Parkinson's, I mean, 40 years ago, we had 2 or 3 drugs. They were okay. The carbidopa-levodopa, of course, changed the whole approach. And now, of course, we have deep brain stimulation. We have various delivery methods to give you the carbidopa-levodopa. So I just want to emphasize that, you know, things have come a long way, thank goodness. Now, my talk tonight is on Parkinson's disease and other movement disorders. And I want to first cover what we call hyperkinetic movement disorders. And the first one we're going to talk about are tics. So you guys know what a tic is, I'm sure. You can have a motor tic or you can have a vocal tic. So a motor tic would be just a brief little, like a shoulder shrug or a head turn. These are involuntary movements. Usually they come on early childhood. It sort of builds up in the patient and they've got to release. And so blinking is another motor tic we see frequently. And then there are vocal tics, sniffing, grunting, clearing your throat. There are complex vocal tics, one's called echolalia, where the patient will say, or you'll say something, the patient will repeat it back to you. And then of course there's coprolalia, which about 10% of folks with Tourette's have this cursing. And I tried to download a video on all this, but it was too large a thing to show. But so anyway, to qualify for Tourette's, you have to have 2 different types of motor tics and a vocal tic that lasts a year or longer with the onset before age 16. And so if you have all that, by definition, you have Tourette's. Anyone in the room have a family member or had a family member with Tourette's? Yeah. Yeah, so in my practice, I ended up having probably about 10 folks with Tourette's. And, you know, can you imagine as an adult going through your life with Tourette's? I mean, I had one guy that he would repetitively do the sign of the cross. That was his tic. And then I had another patient that, you know, she would do this and then pat her leg. And I mean, it happened all day. And, you know, obviously that can be very annoying to the patient. So chorea is another type of movement disorder, and this is sort of a dancing type movement. The good analogy would be break dancing. So, you know, it's this kind of rapid rhythmic movement, and of course the classic disease that presents with chorea, unfortunately, is Huntington's chorea. That's an autosomal dominant condition. 50% of your offspring are at risk of developing Huntington's chorea, and there are other cognitive manifestations of Huntington's chorea. And conversely, compared to Parkinson's, where you don't have enough dopamine, folks with Huntington's have too much dopamine. And so our treatment is focused on reducing the amount of dopamine in your brain. And then lastly, tremor. There are basically 2 types of tremor, okay? There's a postural tremor, or what we call intention tremor, when we go to grab something or try to perform a fine motor movement. And you know, the classic example of essential tremor, Katharine Hepburn, the famous movie star, had what we call essential tremor. And not only did she have a postural tremor, but she had that no head tremor. Do you remember how she went back and forth? And then toward the end, she had a voice tremor as well, which I'm sure, you know, obviously affected her acting. And so Then there's also a rest tremor, and I'm going to go into that when we start talking about Parkinson's. So a lot of people just assume, oh my gosh, I've got a tremor, I must have Parkinson's. Well, that's totally false, obviously. And this essential tremor or familial tremor, it is also an autosomal dominant. So someone else in the family typically has a similar tremor. Now let's see if this doesn't work, because this is a very unusual type of tremor. I've only had about 5 folks in my practice with this. So this person is going to try to stand up, and when she does, she starts having this rhythmic tremor in her legs. And it can obviously be very debilitating and put you at a high fall risk. Does anyone know what this tremor's called? Didn't think so. It's called orthostatic tremor. Orthostatic tremor. And it's rare, and it's difficult to treat. I usually send folks to physical therapy. We try something called Klonopin or clonazepam. We also sometimes try something called Keppra or levetiracetam, some of these unusual seizure medicines. But orthostatic tremor, you guys need to be aware of that, okay? Okay, so as far as hypokinetic movement disorders, of course, Parkinson's, and I'm going to get into that in the next slide, but there's under the umbrella of what we would call neurodegenerative hypokinetic movement disorders, one is called progressive supranuclear palsy. And that particular disease can mimic Parkinson's with the slowness of the movement, plus or minus a tremor. But the cardinal feature of that one is the patient unfortunately develops what we call vertical gaze paresis. They can't look up, they can't look down, they can't look to the right or left as things progress. And so instead of falling forward, what you see a lot with Parkinson's, these folks, because they can't look up or down, they tend to have this sort of posture and they tend to fall backwards. And all of these other diseases, unfortunately, don't respond very well to our Parkinson's medications. Then there's one called Lewy body dementia with Parkinson's features. And that particular condition, the dementia or the cognitive decline precedes the motor appearance with all the other symptoms by about a year. And then they tend to have very vivid hallucinations, visual hallucinations. And the problem with that particular disease is when we throw Parkinson's medicine at them, the hallucinations tend to get worse. So our hands are sort of tied as far as what we can use to treat those folks. And then there's one called cortical ganglionic basal degeneration. That's a mouthful, isn't it? Yeah. And so again, this is under the Parkinson's umbrella, if you will. And that presents really unusual. It's called alien limb syndrome. Alien limb syndrome, where the patient develops a focal dystonia or movement of an arm, and it's foreign to them and they really can't control it. And that is pathognomonic of this cortical basal ganglionic degeneration. And then lastly, there's something called MSA, multisystem atrophy. And that's basically a Parkinson's plus condition with profound autonomic nervous system involvement. They can't maintain their blood pressure when they stand up. Their pulse goes up and down. Anything to do with the autonomic nervous system, bowels, respiration, is effective, and so that's a difficult one as well to treat. Just sort of going. Okay, well, I'm going to keep talking. I don't know why it's things are spinning. Don't you hate it when the computer just spins? I just want to punch it. Oh well. See, it's okay. Okay, well, I'm going to keep talking. Well, so let's talk about some cardinal features of Parkinson's, okay? So the top three, one is bradykinesia, and that just simply means slowness of movement. A lot of people don't know about this, but before or at the very onset of any sort of appearance of motor problems, whether it be shuffling, slowness of movement, very subtle tremor, you've already lost 70% of your dopamine-producing cells in your brain. So that is why your brain needs external dopamine to function normally. So you have rigidity, you have something called bradykinesia. The big one is postural instability. Folks with Parkinson's, if you're in a crowd and somebody bumps you, I don't need to tell you about this, your ability to right yourself and prevent a fall is impaired. And so it's so crucial that you concentrate on posture and balance and trying to prevent a fall. There are non-motor symptoms with Parkinson's as well. Because of the lack of dopamine, gut motility is slowed down, so constipation is a very frequent problem. Difficulty absorbing your medications, right? Anxiety, folks with, the Parkinson's folks in the audience, is anxiety an issue with you guys at all?
Occasionally.
Yeah. Well, part of that can be a symptom of being off, right? Or it can be simply anxiety. And then the big one that we see frequently that precedes the diagnosis of Parkinson's is REM behavioral sleep disorder. This is a sleep disorder that presents with sort of flailing about the bed, talking out loud, obviously not getting a fitful night's sleep. And folks with REM behavioral sleep disorder, if you follow them along, in the first 5 years, there's a 33% development of Parkinson's if you follow these folks along, and then at 10 years, it jumps up to 70%. So if you have this behavioral REM sleep disorder prior to the diagnosis of Parkinson's, those people we tend to follow very closely because they're more likely than not going to develop Parkinson's. Okay, so as far as treatments, we have various treatments available, and there are two approaches here. There's one group, and I'm in this initial group, I think, that we try to hold off starting carbidopa levodopa until we absolutely have to. So it's sort of a step care approach, we call it. We tend to use something called a amantadine early on, or a dopamine agonist, or something called an MAOB inhibitor, which is a very potent antioxidant. And so we'll tend to use those for the first several years, and then when the symptoms start really bothering the patient, we'll pull out the carbidopa-levodopa, which is the gold standard for the treatment of Parkinson's. And what's exciting now, there are various delivery systems now that are available. One's called a Duopa pump that administers the levodopa in the duodenum. And then there's a brand new device that is subcutaneous that delivers the carbidopa and levodopa subcutaneously. That was recently approved by the FDA. So, and those particular delivery systems allow a constant, 24/7 concentration of dopamine in the brain, and so you try to avoid that peak and trough level that gives so many people problems with dyskinesia, on-off phenomenon. The patient will take their medicine and they're afraid to run errands because what if I get off in the store and then they're literally frozen. So these medicines, this new delivery system has been shown to be very effective with that. Oh, goody. Okay, thank you, Dave. Oh, one thing I wanted to talk about real quick about non-motor symptoms of Parkinson's, visual spatial abnormalities. Folks with Parkinson's, they'll have 20/20 visual acuity, but they can't see the forest for the trees, if you know what I mean. Meaning, they're looking out and they're missing things, and they'll go to their eye doctor and, "Doc, I can't see. There's something wrong with my vision." And they'll do all these tests and everything comes back normal. So it's obviously a brain phenomenon. And my professor in medical school, we ended up writing 2 papers about visual impairment in Parkinson's. And it's a significant problem. And so you just need to be aware of that. And what I was talking about, this BioLab, that's the new sub-Q delivery system where there's literally a little needle subcutaneous, and you wear a little pack on your waist belt, and it delivers medicine 24/7, which is really nifty. Okay, so I'm asked all the time, well, Doc, what can I do to slow this down, to improve, and a lot of it's common sense, to be honest with you, but what I preach to my patients, take your medications on time, avoiding high protein meals when you take your carbidopa-levodopa, because that affects absorption, and then, of course, exercise. And you might say, well, what type of exercise is most beneficial? And they've looked at all these different various exercises with very well done placebo-controlled trials, if you will, not placebo, but you have a control group that didn't exercise and one that did. And the one I like to start talking about is the forced tandem stationary bike trials. And that's where the healthy individuals in the front of a tandem stationary bike, the Parkinson's person is in the back, and it's a forced cadence. It's a forced revolutionary type of exercise. And this one particular clinical trial looked at not only Parkinson's scores at the end of 6 months, but they also looked at what we call functional MRI developments in biomarkers in the brain. And so you probably already know what I'm going to say. The exercise group that did that 3 times a week for 6 months required fewer medicines. The biomarkers that indicated what the level of dopamine was in their brain went up, And then the actual neural pathways they could see on the functional MRI improved. And so, you know, cycling is an excellent form of exercise. The Sparks trial was published way back in 2017. They looked at 128 newly diagnosed folks with Parkinson's, and it was randomized to a high-intensity treadmill, low-intensity treadmill arm, and then a control group. And what they found, this was really a safety and efficacy clinical trial, if you will. But over the 6 months, the control group had slight worsening of their Parkinson's symptoms, whereas the high-intensity exercise group remained stable. And you might say, well, what do you mean high intensity? That was 80% of your maximum cardiac, cardiac exercise. And then low intensity was 60% of your max. So you did have to push yourself a little in this trial. Another randomized clinical trial looked at resistant exercises, stretching, and then high and lower intensity treadmill exercise. And they looked at the various outcomes, 6-minute walk test, peak oxygen consumption, and muscle strength. And what the results of this showed was all types of physical exercise improved. As far as the distance on the 6-minute walk test, lower intensity treadmill resulted in the greatest improvement in gait speed. That's interesting, the lower intensity, not the higher. And then only the stretching and resistant exercises improved strength. So bottom line there is you want to do some light weights, some resistance. I'm sure you guys have a really nice gym here, right? Probably more than one gym, I would think. So, you know, light weights, some resistant training, and then some form of cardiovascular exercise. Now, the incidence of Alzheimer's, believe it or not, is going down while the incidence of Parkinson's is going up. You might ask, why? Why is that the situation? Well, as far as the incidence of Alzheimer's going down, we think it's related maybe to improved public health, aggressive treatment with cardiovascular disease, i.e. hypertension, hyperlipidemia. We know those are risk factors for dementia. And then just overall better brain health. But why is the incidence of Parkinson's going up? This is sort of interesting. Smoking is neuroprotective for Parkinson's. It lowers your risk of Parkinson's. So does caffeine, which is very strange. Now, I'm not telling you guys to start smoking, okay? But one hypothesis is very few people smoke anymore, right? And the other big reason we think is environmental toxins, pesticides, air pollution. And what's interesting, they've published several of these studies recently. If you live within a mile of a golf course, and this is related to the pesticides they put on the golf course, you have a 2-fold increased risk of developing Parkinson's versus if you live outside the mile radius. So, I'm assuming no one lives on the golf course here, obviously. But, so I find that really interesting. Okay, this is my crew. Ava's 10, and she and her brother on the right, Caden, they live in Waco. My daughter teaches 1st grade there in Waco. And that little guy, Landon, has a brand new little brother, 3 weeks old. and we get to keep landing every Thursday. They live here in Austin. So I do that. I've gone to the medical school to teach, and then I still go out to a brain injury rehab facility twice a week to take care of patients. So before we do questions, we're going to do a sing-along. Debbie, do they have the sheets? Okay, you might say singing, oh come on. So singing helps us with voice projection. It helps us develop new neural pathways. I can tell you how important music therapy is in rehab. And I've got to hear you belt it out on the chorus. And I wrote a couple of verses for folks I personally know here in the room. So let me get my guitar. Hang on.
Anyone else? Got him. Okay.
I'm not going to use the mic for this. So who knows who wrote Redneck Mother? Anybody? There you go, Ray Wiley Hubbard. Everyone thinks it's Jerry Jeff Walker, but that is incorrect. And I actually use different words. Can't really see that. I need it kind of like here. Oh, wait, here. I'm going to do it here. That's good. I'm going to do this. Yeah, that's good. Okay, here we go. Oh, look at you. I love this place. I'll write him a check tomorrow. He was born in Oklahoma. His wife's name Thelma is. And he's not responsible for what he's doing. His mother made him what he is. And it's up again. Yeah, y'all supposed to come in on the chorus. And it's up against the wall, redneck mother. Mother who has raised his son so well. So well, so well, so well. He's 34 and drinking in them honky tonks. Just kicking hippies' asses and raising hell. Well, you know, he sure does like his Lone Star beer. He likes to chase it down with that wild turkey liquor. He's got a 57 GMC pickup truck, gun rack, got a roller needs love to sticker, and it's up against the wall, redneck mother. Mother who has raised his son so well, so well, so well, so well. He's 34 and drinking in a honky tonks, just kicking hippies' asses and raising hell. Well, here we are at Westminster Manor, where the food is good and the people couldn't be finer. These golden years, each day's a new adventure. Honey, where the heck did I put my dentures? Well, Debbie Pearson, she's the belle of the ball. She's a case manager extraordinaire and education coordinator. She does it all. Tina Millman, she doesn't age a bit. She's been like a second mom to me. She's got true grit. Dr. Kent Beasley, he's one heck of a guy. Amazing cardiologist, and friend, I wouldn't lie. M is for the mud flaps. She gave me on my pickup truck. O is for the oil I put on my hair. T is for T-bird. H is for preparation. E is for enema. And R is for redneck. Well, it's up against the wall, redneck mother. Mother who has raised a son so well, so well, so well, so well. 30 and more, drinking in a honky tonk. Chipping Jimmy's ass and raising hell. In the Skokie, Oklahoma, USA. Okay.
The questions.
I'll be glad to answer any questions for anyone.
Okay.
Could you talk about adaptive DBS?
What do you mean?
Well, I read about it in the AARP magazine.
Adaptive deep brain stimulation?
Yes.
That's a new one on me. What did it say? I'm curious.
I have to read the magazine.
I get AARP.
Yes, there's a little article about it. I'm not sure if it's this month or last.
Okay, well, I'll look that up. What? Interesting. I just know there are lots of new developments with deep brain stimulation, and when I finally left my group, I had about 100 DBS patients I was following, and the majority of my patients felt like that was a very, very beneficial treatment. A lot of them, unfortunately, after they were implanted, for some reason, we're not quite understand this, but their balance just went to, they have very impaired balance and seem to have more falls.
I think they were talking about it being able to, the x-rays were able to pick up differences in the brain, I suppose, in the stimulation, so that there was less on and off periods, or
Yeah, maybe the new technology can pick out those dopaminergic pathways that should be turned on or turned off, depending on your stage of Parkinson's or your what you're doing from a behavioral standpoint. Yeah, but I'll look into that.
Okay.
Adaptive DBS.
Thank you.
Anybody else have a question? Yes.
I take it that this is a character. And if it's
We'll bring it back to you.
Oh.
My nephew just, we heard 2 days ago, he was diagnosed with Parkinson's. And I talked to him today. And he said, one of the things that he says that when he tries to stand up and walk, he's not stable and his legs are shaking.
Yes.
What does it mean?
Well, yeah. Well, one, I hope he was given the correct diagnosis, because you saw what orthostatic tremor is, but maybe he's not. Is he describing tremor in his legs, or he just felt unsteady?
No, he has difficulty in walking.
Yeah. So folks with Parkinson's, when they try to change positions, it's very difficult, and a lot of them have freezing, where they can't advance their feet. And then the other one I didn't talk about is called festination. It's where your head gets in front of your body, and you're on your tippy toes, and you're at a huge fall risk for a face plant. And so part of what we try to do with the freezing part is there's a U-step walker with a laser and a cadence, like a metronome, and the patient listens to that metronome, and it allows them to walk and decreases freezing. And then as far as the festination, trying to stay off your toes, we always recommend a heel strike first. Heel, toe, heel, toe, heel, toe. And then some folks tend to festinate so bad, I'll actually put Botox injections into their calf muscles to slightly weaken the calf muscles, and then they can't get up on their tippy toes as much. But, so you said your nephew?
Yes.
Yeah, is he young?
Just 8 years.
Yeah, that's pretty young, but where does he live?
New Jersey.
New Jersey. Mhm. Well, I hope he does well. Yeah.
I take it from all you've said that Parkinson's is inherited, but you also said it's going up. Does that mean the gene pool is getting worse?
No, it's not inherited. Only a small group of folks
So
have a family history. It's de novo. You can get it out of the blue. You don't have to have a family member with
So
Parkinson's.
what causes it? What's the precaution?
Well, risk factors, we sort of went over those, but I'll go over again. I mean, one, if you've had a brain injury or a concussion, think of Muhammad Ali, the boxer, right? So that's a risk factor. These environmental toxins, we talked about pesticides. If you ever exposed to Agent Orange in Vietnam, or pesticides around your home, unfortunately, you can have a really healthy lifestyle and end up getting Parkinson's. So there's no rhyme or reason, really. Yes?
What are the benefits of the singing or playing musical instruments that y'all are testing on this trial that's coming?
Yeah, so this is really fascinating. When we sing out loud or even play an instrument, hopefully you guys are familiar with this term, neuroplasticity. We used to think, and neuroplasticity is the brain's ability to develop new neural pathways, and I'm not talking about just after a brain injury. I'm talking about trying a new novel task that you've never done, or learning a new language, or learning a new hobby. Believe it or not, whether you're 8 or 80, our brain has that ability to, with this neuroplasticity, develop new neural pathways. And so what they've discovered specifically was singing or playing a musical instrument. Those new neural pathways that are developed are very, very beneficial in producing more dopamine in the brain and improving Parkinson's symptoms. That's why we're really looking into this, and it's very exciting.
That's exciting,
Yes?
yes.
Can you hear me?
Yeah.
There's a light.
Oh, thanks. I have Parkinson's. In fact, you were my doctor. You probably don't remember me, but maybe you do. Anyhow, I'm still here.
Still kicking.
Yeah.
Good.
I wonder about a couple of things. One is I had a very elaborate test. I had a very elaborate test to check the presence of dopamine in other parts of the brain. I don't remember all the details that involved going, So I'm pretty sure I have it. But it's also hard for me to sort of distinguish between, say, for instance, the instability you have because of Parkinson's and the instability you have because you're 82 years old.
Right. No, that's a good point. Yeah. Because you can have postural instability and not have Parkinson's, right? So the part of the brain that controls our balance is called the basal ganglia. And as we get older, unfortunately, those circuits going from basal ganglia to the cerebellum, which is the balance part of the brain, to what we call the prefrontal cortex are affected. And so you don't have to have Parkinson's to have postural instability. Unfortunately, with Parkinson's, though, your ability to right yourself once you're going down or correct your posture is impaired compared to somebody without Parkinson's. And so you're at a higher fall risk than somebody that's 82 or whatever without Parkinson's.
Yeah. And I have a follow-up question, which is just my situation. Right after you and your crew, after you and
Oh, that's good.
after you and your crew had me take various kinds of drugs to mitigate the symptoms, I finally wound up taking what I take now, which is carbidopa, levodopa, and misogyline. That's the kind of standard thing, I think. And I think that what I've understood is that no drug will deal with these symptoms permanently.
Correct.
Why? Do you have any idea why that is the case?
Well, it's very frustrating, but the medications honestly don't improve balance. The main thing that improves balance is physical therapy. Yeah. In fact, too many medications, of course, they all can butt heads with each other and make things worse. So you want to, I like that combination with rasagiline and carbidopa, levodopa. That's a good approach.
Is there any definitive test for Parkinson's?
There are two tests that are fairly specific and sensitive for Parkinson's. One's called a DAT scan. There are only 2 DAT scanners in the whole city. It's ARA, and it measures dopamine uptake in the basal ganglia. And the other, believe it or not, is a skin biopsy that's been developed recently, which is actually even more specific than the DAT scan. And very few neurologists are doing the skin biopsy. So, but the answer to your question is skin biopsy and the DAT scan can basically nail the diagnosis.
Interesting. Where are we?
Is there a point in the treatment of Parkinson's when you reduce the dosage of dopamine?
Yes, that's an excellent question. If the patient has developed something called dyskinesia, have you guys, I'm sure you've seen Michael J. Fox interview recently. That poor guy cannot sit still. Remember Rodney Dangerfield, the comedian? Yeah, they're killing me. But Michael J. Fox, he's just all over the place. So for him to be on, he has to be dyskinetic, because that poor guy has to dose about 1.5 hours, every 1.5 hours. So if we're giving too much dopamine and this dyskinesia develops, that's a sign that we need to back off a little on the dopamine, although some patients, this is somewhat unusual, they have end-of-dose dyskinesia where their medicines are starting to wear off, and during that trough, they get dyskinetic, but that's not very common. The other reason we would want to reduce carbidopa, levodopa if the patient's having too many visual hallucinations, because that's one of the main side effects of carbidopa, levodopa is visual hallucinations. And I'll just comment about that. The patients with visual hallucinations early on, they know what they're seeing isn't real, okay? But they can't convince their brain what they're seeing is not real. So one little technique I would tell my folks, okay, get your flashlight out and shine it at the person. And of course, the light goes straight through them. And the other thing with visual hallucination with Parkinson's, the person never talks back to them. And so most of the time it's not a scary hallucination, although it can be. I had a patient that she would cook the meal. She lived with her daughter, but she would cook a full meal, sit down at the table, and then the plate full of food was across from the table for this imaginary hallucination, and she would just talk to the plate basically the whole meal, and that went on for years until the daughter kind of stopped that.
Could I ask just a specific specification of dyskinesia? I have restless feet sometimes. Is that a form it takes?
It is, that's a form of dyskinesia, yeah. Here's a little pearl. The most common cause of restless legs, unrelated to Parkinson's, believe it or not, is iron deficiency. So anyone in the audience with restless legs, you gotta move your legs at night to get comfortable, ask your doctor to check your ferritin and serum iron level.
It's a jewel.
I just want to put a plug in here. Power for Parkinson's. I'm on the medical advisory board of that. It's a nonprofit here in town. There are 7 different locations. Do they exercise here? Anybody know? Power for Parkinson's.
Twice a week.
Here?
Yeah.
Good. Yeah, so Lauren Lewis and that whole crew, that is just such a wonderful group, and they get the caregiver involved, and it's like one big happy family, if you will, and they do a lot of social events. But Power for Parkinson's, and then CAPS. Do you guys attend CAPS, Capital Area Parkinson Society? That's another very common resource that's a good resource here in town.
It's dead. No more questions. The mic is dead. No, are there any more questions?
Well, do you have one, Bill?
Well, it pertains to me, so I'll ask you.
Okay, we'll talk afterwards. I just want to tell you how honored I am to be here tonight, and hope you guys have learned something. And Dina Millman is in the room. I was hoping Dr. Beasley was going to be here, but I talked to him the day before yesterday. He said he was going to come, but I guess he didn't make it. But. Well, good. Well, I would love to come out again next year and talk on something else. So everyone have a good Thanksgiving. Thank you.